Well, hello, everybody. My name is Garrett Schmidt, and I am the managing editor and CEO of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Lightbeam Health and CareSignal, which is a Lightbeam subsidiary. And it is titled Addressing Social Determinants of Health in Your Community with a No-Cost Tool. And I'm really excited to hear from these guys today, guys and gals. And we've got some great content that I think you're all really going to enjoy. A few items of note before we get started. We do want to hear from you. So during the webinar, at any time, please feel free to ask a question. We are going to have a Q&A time towards the end. And we'll go through as many as we can in the allotted time, but you don't have to wait until then to ask your question. So go ahead and ask it. In your attendee module, there's actually a place for questions. So go ahead and put it there if you would, and we're going to get to as many of them as we can. If we don't get to yours for some reason, we will make sure to reach out via email afterwards and get your question answered then. So even if we're wrapping up in the last 10 seconds, go ahead and submit your question and we'll get back to you. And then finally today, the session is being recorded. So what's going to happen is when we're done, I'm going to send everyone a link to the recording, and there will be also a place where you can download the slides. So you'll receive that from one of us maybe an hour or two after the conclusion of the presentation. So without further ado, I'd like to introduce very briefly our presenters today. First of all, we got Mr. Blake McGrath, and he is the CEO of CareSignal, which is a Lightbeam company. And we've got Soy Chen, who is the Chief Data Scientist of Javion, which is also a Lightbeam company. And then C. Stavridis, I practiced this, C. Stavridis, who is the VP of Product for CareSignal, which is a Lightbeam company as well. So Blake, I'm going to turn it over to you at this time. I think you're going to get us kicked off. So welcome, guys.
Thanks so much, Garrett. And C and Soy, thank you so much for carving out time as well. I'm really excited. I'm grateful to have the chance to share this today. I've been looking forward to this specific presentation now for just about half a year because the entire Lightbeam organization and I are very, very proud to be the first to offer a completely no-cost health equity strategy tool to any healthcare organization in the United States available today. And I'm excited to show you what that is and talk about how we came to the decision to open that up and how that also aligns with the overall direction and strategy of Lightbeam as a population health enablement organization that strives to deliver as much financial and clinical value to our partners, which are some of the most innovative payers and providers across the country as possible. Agenda today, very straightforward. I'll spend just a couple of beats sharing some of the latest literature on health equity. A couple of days ago, for instance, we saw some of the proposed rule for the 2027 plan year for Medicare Advantage, which itself has some new insights. So really, this should be a nearly up-to-the-day quick summary of where health equity stands, not only as a recommendation, but also as a financial mandate. And then we'll discuss the data science that allow us to deliver this health equity AI tool called Radian. Then we'll demo Radian. As Garrett mentioned, C and Soy have taken the time to join today because they're the creators of this tool. I've drafted up a couple of questions that I think will help give a window for everyone here into the technical sophistication, as well as the intentionality of design behind this no-cost program. And then, time permitting, we'll take a quick beat and discuss what I mentioned at the very top, which is the big picture, the overall direction that we, Lightbeam, are building toward as the population health enablement company that builds pathways to success in value-based care for our client partners nationally. With that, let's go ahead and dive in. A couple of publications here. One that I really like because it defines the still somewhat amorphous concept of health equity. Health equity means reducing and ultimately eliminating disparities in health. It means that a standard of care should net the same outcomes if it is delivered in the same way, regardless of to whom it is delivered in a community. And everybody on this call today knows that unfortunately that isn't the case. There are challenges, often called social determinants to health barriers, that preclude equitable outcomes from being achievable. CMS is now fully on board with that. Everyone here is familiar with the new ACO REACH program, which at the very back end determines part of compensation based on the geographic benchmarks from a health equity perspective, the Area Deprivation Index. And this is moving into, I really like this line, this heightened social consciousness as well. Who knows whether we will add a fifth lobe to the quadruple aim, and whether that could become the quintuple aim, which now includes health equity, but certainly a topic of conversation. And to make this even more timely, pulling some of the latest, both consulting and journalistic literature, all eyes are on health equity as a driver of reimbursement and financial performance in the context of the shift to value-based care, where health equity and culturally sensitive care delivery and holistic or whole patient care are all flowing together, and they will be incentivized. And I think that's intuitive for us. We know that if we're taking risk on the whole dollar, if we're serving a fully capitated population, part of that service needs to extend beyond chronic condition management, needs to extend beyond the ICDs of old, and move into truly preventative care, including support that goes beyond traditional healthcare. But how? And all of this begins by collecting all potentially relevant data points. In the case of the Lightbeam Health Equity AI offering powered by Javion, that means pulling together thousands of different factors and attributes that will have some bearing in predicting the potential challenges and opportunities that a population will face with regard to health equity. And this list is pretty intriguing. I think all of us would intuit, for instance, that data from the EPA, perhaps around air quality and environmental contaminants or pollutants, could drive someone's health. That makes sense. Housing, urban development, that one makes sense too. But we go so much further. We pull in these data points from the Department of Agriculture, from US Census Bureau, of course, CDC, the National Provider Index. And pulling all of the data together is just the first step. That's a really good data set. But how do we turn that into proactive, prescriptive insights that can identify opportunities that everyone on this call can take to serve their patient populations or member bases and prevent health equity disparities from arising or being perpetuated? And to do that, let's go ahead and put ourselves in the shoes of a social worker teammate whose mandate is to help support a patient. And let's just think of one specific patient where we know, at the very leftmost graphic, we know that this individual is living in a food desert. We know that that's a yes. And then we learn something else. We learn that this person has social support. So ask a question, do you have social support? And we figure out that, yep, sure enough, this individual is likely to have a pretty good family-based support network that can have implications we could imagine for everything from transportation to loneliness, all sorts of potential SDOH or health equity drivers. And then let's add another feature. Let's add another parameter, digital fluency. Is that low or high? And you can imagine how, as we add more and more of these different attributes, the potential challenges and opportunities and recommendations for this specific patient become more and more sophisticated and nuanced, but also, frankly, overwhelming. If we keep adding these features, eventually, remember, putting ourselves in the shoes of that LSW, of our own teammate, eventually it becomes next to impossible And by the way, when do you have time to think through every potential driver of health equity and then to apply your years of experience and intuition and think about how to help that patient as effectively as possible? You just don't. This isn't the focus of today's webinar, but you'll notice that through every single thread of the LifeBeam offerings, staffing scalability, burnout prevention, top of license enablement are all top of mind for us, because without those things, even the best technology will stumble. Moving all the way over to the right side of this slide, though, and it's a little bit hard to see that orange circle that goes from the light purple to dark, or the magenta to purple there. But the entire purpose then of prescriptive artificial intelligence is to figure out not just the current accurate snapshot of that patient, but what specifically can be done to have the greatest possible positive or preventative impact on that patient's outcomes as measured by PMPM spend of all of the different possible scenarios. What very specific 1 or 2 or 3 levers can be pulled in order to drive outcomes for that patient? And that, in a nutshell, that is the essence of health equity. Taking in lots of data, functionally emulating years, decades, even hundreds of years of experience of some of the best theoretical teammates possible, and then applying it by boiling it down to a very actionable set of 1 or 2 or 3 recommendations, where if acted upon, those prescriptive recommendations will drive an impact. And I think a fair question for everybody to be asking at this point is, does it work? And the answer is a resounding yes. The Javion-powered health equity AI models show a coefficient of determination performance that's more than 10 times better than that of the CDC's own social vulnerability index. And that's really powerful, because if you can't rely on the metric you are using to be an accurate benchmark to help affect the type of change that you want to affect, then it's not a good tool. And we'll dive more into this. This is one of the discussion points that I'll invite Soy specifically to comment on after we go through the demo of this health equity strategy in a box. And without further ado, let me go ahead and dive in. So what I'm about to show you, very important to note, what I'm about to show you is available to everybody on this webinar. I'll ask one of my teammates to please post a link so that you can request this in real time if you like, or you're welcome to watch the demo and gauge whether this could potentially be helpful for you or your organization. But let's go ahead and dive in. So let's go ahead and build our own health equity strategy in a box. And this is going to contain 2 things. First, this is going to show us, for a specific organization, geography-specific insights, opportunities to create positive impact for a very targeted population within a given community. And second, this strategy in a box is going to go, call it the extra mile. This is going to create community-facing materials that anybody on this call could download and deploy across a broad range of media and formats in order to take the insights generated by the health equity models and turn them into actual outcomes within the targeted community. And as I'll describe as we go through this process, and as you can read from the bullets on the screen here, we've gone to great lengths to make this not only a very simple and, of course, financially accessible by virtue of the fact that it's free, not only a simple and accessible tool for you, the healthcare organization, but also a deeply identity aligned and accessible tool from the perspective of the communities and individuals in the communities that you serve. So we'll talk more about that as well. And then just to throw the hook into the future as well, that's one of the questions that I'll invite C to speak about as soon as we wrap up this demo. So let's go ahead and dive in. I'm really excited. I've decided for the first one of these couple of demos that I do, I'd like to use Unity Point Health. And Unity Point was a role model health system for myself, when I started the company that I was fortunate to then sell to Lightbeam. UnityPoint was one of our first investors and supporters. And UnityPoint has one of their locations at zip 50309. And by entering that zip code, we're then given the option to select the radius of interest. 1 mile, that might be really appropriate for targeted federally qualified health centers in urban environments. 10 miles, which is I think the option that we'll go for here, that's good for maybe organizations in suburban areas or larger hospitals that are serving a broader catchment area. And then of course we can even zoom all the way out to 100 miles to get general insights that are less specific, but that could be really useful if you're exploring expansion into a new geography and you want to know what some of the most common health equity challenges and opportunities you'll face are likely to be. And with that, we can click View Data. In real time, this program will pull in data from almost 300 block groups around Des Moines. Now, block groups, which you see here in the very top, are essentially the much more granular version of zip codes. You know, the zip code with those extra 4 numbers at the end that help your letter arrive way faster, those are block groups. And these nearly 300 block groups contain 181,000 households, just under 500,000 individuals living in this area around Des Moines. And now we can dive into community characteristics. Keep in mind, we're not at the artificial intelligence part yet, not by any means, but these are helpful characteristics and attributes that could inform how you approach serving your community. Let's describe how. Walkability index. Walkability index ranges from 0 to 20. Walkability index of 8 might suggest that while some folks, perhaps those in the more urban areas, are able to walk to certain resources, everything from food to community-based organizations or public transit, lots of folks cannot. They're not that fortunate. Poverty rate, 11%, 4.7% uninsured, and we see the reported race or ethnicity, noting that we've decided to include both race and ethnicity, Hispanic or not Hispanic, together here. We get a quick snapshot of health literacy and specifically whether individuals speak English less than well to a high degree, seeing only 2.6% of folks in this area broadly around Des Moines speak English less than well. And then we see, this is really cool. Imagine how powerful this can be, especially at a 1 mile radius when you're designing your screening strategy in order to figure out where to deploy resources or campaigns to a population to close any of those measures from a screening perspective. We can see that overall breast cancer screening is slightly below the national average. That might be good to keep in mind. Cervical cancer screening is well above the national average, and colorectal is below as well. And as the final step before we move into the AI-generated insights, we get a quick sense of the healthcare providers that are within a 10-mile radius of this area. And now with a click, we can run the predictive models, pull in the data from those sources we discussed, everything from census to housing, urban development, and more. We can model those potential interactions. Remember that discussion. It's not just about pulling all the data together. It's about figuring out where a single lever can have the greatest possible impact. And then what we see here are the 6 AI-generated opportunities for maximum impact throughout this population. I would like to point out that the greatest opportunities for impact are not necessarily the biggest social determinants of health challenges. For instance, in a highly rural population where there are food swamps, where Dollar General might be a go-to for a lot of community members in a population, even though we would love to see nutrition be the greatest opportunity for impact across all of the block groups in that area, that might not be the case. And I don't know, but that might be why we see nutrition here instead of even higher up. Instead, what we see is from an opportunity to affect that, again, once again, greatest possible impact clinically and financially. First is mammograms. Second, access to care, educating folks that if they're experiencing a hard time setting an appointment or getting to an appointment, All of those things fall into the category of challenges with access to care. And they might be surprised to see, as we'll see in the materials in just a moment, that those types of barriers affect the majority of Americans. Maybe they don't realize that what they're experiencing is both a problem and something that can be solved and needs to be solved. We see health literacy and education. Oh, internet access. This one is one of my favorites because it really is a testament to if we can broaden internet access, we can dramatically improve clinical and financial outcomes, especially for risk-bearing organizations. Nutrition, as discussed, and then screenings for older women. So let's go ahead and go to the next step here. Let me go ahead and grab a logo that we can use. And this is part of the completely free offering that we're privileged to provide to everybody on the call today. What we can do is, if you like, use your organization's logo and select a color that's automatically generated to best align with your brand aesthetic. I think 4 looks really nice today, so let's use that. And then we do something really cool. We actually match AI-generated faces that will align best with the race, age, and other identity characteristics of your community. We match those faces into a broad range of different materials. And then we also pull together a subset of clinician-facing recommendations so that your clinical teammates are empowered to reach out, not just with a proactive recommendation, but with specific types of guidance that are most likely to benefit the community members by, again, starting with those AI-generated opportunities. And all of this comes into a single exportable report that we can either share as a PDF with you or email to you. We email you a link so that you can download it yourself. And it starts by summarizing that same dashboard where we started. What are the community characteristics? We then recap some of the health characteristics within that community, including access to care. Again, potentially really powerful. And this could be generated on a clinic by clinic basis, or if you're exploring a new region, or perhaps even a new partnership, we could take it a step further. And then we summarize the top AI-generated insights as opportunities for impact. Now we get to the new part, the really fun part. As you can see, if you can see the scroll bar, we create dozens to hundreds of different materials in order to accommodate print, mailer, in-office, digital media, including social media or EHR blasts. And we automatically brand these materials with your preferred brand, and then pull in, as I mentioned, AI-generated faces to maximize the alignment of these, again, in real-time generated materials with your community. We create a few versions of each just to make sure that we're going to meet your community members where they are. And we create those for all 6 of the opportunities that you're facing, or the AI-generated opportunities that are identified for your organization and the geography that you choose. Here we go. As mentioned, in 2021, over 95% of Americans reported at least one barrier to healthcare. Huh. Wow, yeah, that might have been me. Maybe I can learn more about that. Maybe I can talk with my care team about that to help overcome that barrier. And I really do want to try to find internet access. It's just one of my favorites. 1 in 4 Americans lacks access to broadband internet, and having access to internet can help. And here's a link to a resource. Again, this ideally is designed to require minimal literacy, let alone health literacy. All you need to do is pull out the camera app on your phone and link through to the appropriate resource. So I do want to flow down to the very end here and give you a sense of the clinician-facing materials that we also provide. So here we go. So here we go. Health disparity and advancing mental health disparity are a handful of the clinician-facing resources. And again, now your social work team, I'm sure, could intuit this, but it's great to have the extra focus. Now it's more than just, well, you should probably help make sure folks have access to transportation. We go as far as providing a few prescriptive guidelines that might help inform your strategy in serving this specific population. And again, these will be unique based on every geography, every population, automatically generated, customized for not just your organization, but the specific area and community that you serve. So let's go ahead and hop back here to the presentation. Just to recap, this just no cost, ready to go. This offering is available if you head to the URL lightbeamhealth.com/radian-demo, and includes those two major categories of deliverables. First, executive level insights that you can use perhaps to validate your existing strategy or to put together a strategy for advancing health equity for a population, whether it's broad-based or as specific as a 1 mile radius. And then if you like, we also provide those community aligned materials that should help resonate from both an identity and a challenge perspective with the individuals in your community that have the most to gain in terms of health equity. So thanks for sticking with me. I would love to invite now Soy and C to hop onto video if you're able. And I'll start intros while Soy Chen and C Stavridis join. So quick intros. First, I can't emphasize enough what a privilege it is to work with these two teammates and executives. Soy is our Chief of Data Science at Lightbeam, and she leads efforts in building AI products, broadly to improve patient lives. That includes health equity artificial intelligence, as well as a broad range of clinical AI models, everything from managing avoidable admission reduction to all-cause readmissions, 30 days, to ED utilization. And Soy has deployed products spanning acute care to community population health, and even before joining Javion, which again is now proudly part of Lightbeam, Soy implemented machine learning tools covering fintech, consumer tech, commercial, and more. And C Stavridis, my co-founder at CareSignal, is a VP of product. In addition to deep value-based care and patient engagement technology experience, C has a pretty unique background. They're about as multidisciplinary as one can be. They led healthcare innovation and design courses at Washington University in St. Louis, and also worked at that same institution within the Healthcare Communication Research Laboratory. C, Soy, welcome. I can't see you, but hopefully you're on. Can you see and hear me okay?
Yep. Yeah.
Awesome. All right. Well, thank you again for what you've created and for joining. Soy, I'd love to invite you to answer the first question, and let's kind of frame this as, because you've seen a lot in healthcare AI and machine learning. So compared to the other AI models that you've developed, for instance, that predict all-cause readmissions or emergency department visits, I think health equity can seem a bit abstract. We've touched on the R-squared for PMPM prediction, but could you speak for just a little bit as to how you measure success for health equity models, and how you and your team measure success for those models' ability to predict healthcare utilization?
Sure. So we defined healthcare utilization for this product on ED visits and unplanned inpatient admissions. And we chose these as the target of our model because a lot of disadvantaged populations consume healthcare differently. And for instance, those who resort to ED or have unplanned inpatient admissions may be lacking resources to access preventive care or routine checkups. So those elements of utilization were the focus and target of the optimizations that we used to have the output of the product. And so when we wanted to measure success of the model as inaccuracy, we used the same utilization metrics.
Awesome. That's really helpful. And C, then really you decided to pick up where Soy and her team had left off, and you familiarized yourself with Javion's models and decided that it was really important to make the concept of health equity AI as accessible as possible. And I think the key word there is the concept of, because part of what the Radian tool does is not just produce insights, but also help show some of the most innovative organizations and executives the power of AI. Can you share a window into the process that you took in order
Sure.
to help folks understand?
Yes, absolutely. So as I was getting acclimated with the models that Soy's team created at Javion, what really stood out to me was how they aligned health equity insights with those tangible outcomes Soy spoke about, the unplanned inpatient admissions and ED utilizations. And that's one of our guiding principles at Lightbeam, turning insights into outcomes. So with that principle in mind, as I performed market research and interviewed executives at value-based care organizations, it became clear that we needed to develop a robust and valuable tool that didn't require or doesn't require any confidential data to offer health equity AI insights. So no PHI or no PII. And Javion's models enabled me to offer just that. So Radian was developed on top of these models as a free and accessible tool for all organizations, from the most sophisticated and well-resourced to those that may be struggling with the staffing limitations that Blake mentioned and may be worried with about the performance in the years to come.
That's well said. I think a couple of key points there. First is, I mean, as everybody who took the time to join today saw, really no confidential proprietary information required, let alone any PHI or PII, which just makes it much easier to use software these days. That's a really good point, C. Thank you. Soy, coming back to you. So you've led Javion in developing prescriptive recommendations that go way beyond correlative risk factors and move toward actually preventatively solving problems. I think that I butchered the initial introduction into how prescriptive AI actually comes together. Why is it challenging, and why is it also so important in the technology you've built?
Sure. So this is challenging and important because we want to recommend the most impactful actions that make the most difference. Because having just the features that describe the neighborhood or describe the demographics of the population is not going to tell you how it's going to change an outcome and what will be effective. And by utilizing the model to tell you what to action, we can then know that these are the true drivers that will have an effect on the outcome. And so we connect the model output features based off of the importance of the drivers to the model output and the weights given to the population and the relevant recommendations derived from literature review. And we combine it all to have this robust client actionable, not client actionable, these evidence-based actionable documentation that has a lot of research built into it so that you can read up on what the top clinical standards are that back up the recommendations that we put into this documentation.
Excellent, thank you. And C, coming back to you to bring us home. So everyone has now seen the Radian Health Equity Strategy in a Box offering. Floor is yours. What are a couple of small details that you're most excited about or proud of when it comes to this product?
One of the details I'm proudest of is the way that we apply AI in different ways with Radian. So again, its foundation is based off of the models that Javion have created. So we raise those health equity AI insights and pair it with the incredible evidence-based clinical guides that the Javion team has developed, so teams can move those insights into actions. But we also use AI in a subtle way with the AI-generated portraits that are matched with the communities that are targeted or included, excuse me, in the areas that are in each report. And these materials combine our health communication best practices from being readable at a 4th grade to 6th grade reading level or including imagery that resonates with the particular topic we're trying to convey with those AI-generated portraits to reach that maximum identity alignment that Blake was talking about with community members, so that these materials can resonate with those members and hopefully lead them to the different CTAs, whether it's a QR code or a very simple URL that leads them to an action to enact on their own a health behavior that could impact those outcomes we're trying to drive. So Blake mentioned internet access is one of the themes. We link community members directly to federal funding or a site that includes federal funding or subsidies for their internet, so they can make that action on their own before speaking with your organization. For other conditions like high cholesterol, we link them to evidence-based risk tools where they can assess their own risk, and we ask them to, after assessing the risk, reach out to their provider. So putting some of the impetus on the community member to help raise their awareness of those particular insights. Another thing I'd like to highlight is the fact that Radian is a standalone product and is offered for free. And while it's a key part of your strategy, as you develop that health equity strategy, we have many other offerings that can you can take along on your journey should you need them, from analytics to benchmarking tools and reporting tools.
Awesome. See, thank you so much. And Soy, thank you both so much for taking the time to join. And see, that was incredibly articulate. And I think let me jump forward just a couple slides to pick up right where C left off, which is as we, through some of our top channel partnerships, have brought this Radian tool to organizations from some of the scrappiest federally qualified health centers in the country to some of the highest performing accountable care organizations. The question that we understandably get is what's the catch? And for organizations out there, I think it's fair to say it would be Lightbeam's privilege to show you all of the ways that we're investing in building the industry-leading technology solutions to help you thrive as you proceed down various pathways to value-based care in a world of staffing burnout, of ever-changing incentive structures and requirements, and where, frankly, a lot of organizations, including those serving some of the most underserved populations, are experiencing unprecedented financial pressures. So the short answer is, exactly as C said, we're offering this at no cost because it is the right thing to do. Health equity needs to be ubiquitously accessible, not just for every patient or member, but also for every organization serving those patients or members. It's the right thing to do, but we also believe it will show that we as a company have so much to offer in terms of helping you perform and succeed. C mentioned, for instance, the analytics capabilities that we've built around health equity that can apply to, for instance, ACO REACH, the enhanced oncology model, that will absolutely apply to the health equity index reward that CMS intends currently to roll out for the 2027 plan year, which will be based on data used from 2024 to 2025, and is designed to further encourage Medicare Advantage and Part D plans to improve care for enrollees with certain risk factors. We've gone to great lengths as well with this analytics platform to pull together block level area deprivation index data. To our knowledge, we're the only technology partner in the industry right now to offer this level of granularity, which is critical because ADI is the benchmarking for ACO REACH performance. We also offer extremely accessible and engaging deviceless remote patient monitoring for a broad range of chronic conditions, behavioral health conditions, and of course, for social determinants of health, longitudinal monitoring and engagement, all designed to scale your care coordination and care management teams. And the Radian AI tool, the no-cost health equity offering, is just the tip of the iceberg. What Soy and the data science team that she leads have built goes so much deeper providing dozens to hundreds of additional insights for communities, and even going down to every single patient or member, starting with just a roster to identify not just, for instance, that this community is most likely to benefit from increased education on mammography resources or nutrition, but going way deeper to say, hey, every single person that you serve on a roster provided can benefit from very specific prescriptive courses of action, as Soy was summarizing, with the evidence-based clinical resources that we pair to make sure that those proactive insights come with recommendations that can be acted upon and the impact of which can be tracked. And that flows through to the overall comprehensive light beam vision of population health enablement. And starting at the very top, we pull together data from post-adjudicated claims, health information exchanges, EHRs, of course, ADT feeds, pharmacy data where available. Then we process those data and overlay the predictive models that Javion brings to the party in order to figure out not just where there are the greatest challenges, but as mentioned, both for clinical and health equity use cases, where we as an organization can surface for your existing resources and capabilities, the opportunities to have the greatest possible impact. We use best-in-class adjusted clinical group cohorting to figure out where you can start, because it would be nice to think that we could all boil the ocean and serve every single patient or member in a population, but the reality is it may make the most sense to start with the top 1%, 2%, 3%. And then deviceless remote patient monitoring at the bottom of this slide is how we go from the top 3% to the top 20% of patients from a cost and risk perspective. That's how we scale your care management and care coordination capability to perhaps even an order of magnitude more patients than would otherwise be possible using just a manual outreach model. And if you don't have the staff, which is a completely reasonable position to be in today, if you don't have the staff to do that, we do. We have the technology, and we also have staffing options to make sure that your organization can enact all of the insights that Lightbeam generates through a combination of AI and best-in-class cohorting. And all of that then shakes out to a full closure of the feedback loop, because the population health insights at the very core of Lightbeam Health Solutions also allow you to track your performance longitudinally and demonstrate where you're performing and where the ROI is. I think that's goes without saying, or should go without saying, but that rapid return on investment and a clear line of sight and time to value is critical if you're going to make smart choices and also measure your own performance in a world of value-based care. So we've covered a whole lot of ground really quickly. We are right on time at the 45-minute mark. Just one more reminder. If you're interested, it would be our privilege as a team to create and share with you these health equity reports. If you'd like different reports for different areas, you're welcome to submit. We have this form. I wish that we had the option to type in multiple, but we're glad to also create these reports for multiple geographies. And then if you would like to dive deeper on the overall health equity and even beyond health equity analytics, on staffing scalable deviceless remote monitoring and engagement, and on all of the other offerings, both individual level health equity AI as well as clinical models, it would be our privilege, of course, there too, to dive in with you and share some of the impact we've had with over 100 of the largest payers and providers across the country that we serve today. With that, I would love to jump into Q&A. Garrett and team, if we have any questions coming in.
All right. Well, great. Yeah, this was a wonderful presentation, and we do have some questions, as a matter of fact, that have come in. So without any priority here, I'm going to go into these questions. The first one is pretty simple. What are you offering for free?
Sure. So the what we're offering for free is that full health equity AI report, both the snapshot of the community or multiple communities, if you prefer, that your organization serves at the 1, 10, or 100-mile radius, paired with the community-facing resources that you could deploy via whatever media makes the most sense, as well as the clinician-facing resources, again, Don't presume to think that that you need to educate your fantastic team on how to serve patients, but sometimes it can be really helpful to put just the right recommendations and tools in front of licensed social workers and other teammates that are working so hard.
Yeah, wonderful. Okay, next question. And again, if you have a question, go ahead and submit it now. We're going to get to as many of these as we can today. I think we have time, but if you don't get to yours, we will get to you via email afterwards. So go ahead and ask your question. Next question is, if I schedule time, can I have multiple reports for multiple clinics?
Yes, absolutely. It'd be our privilege.
Great. Next question here is, let's see, how do groups use the community resources?
Sure. So what we found is the groups use community resources to fill in gaps in their current strategies. Assuming that in this case, community resources is referring to the community-facing materials, flyers, social media. Thinking about, for instance, a large multi-specialty physician group that only provides outpatient services, that group finds the most value in deploying those branded insights, again, branded with the aesthetic of the organization and the logo for familiarity and credibility in the offices. So that if patient is walking by and decides, yeah, you know what, I do resonate with this. I have experienced some challenges getting to my appointments in the past. It's just that one extra thing that can help close that potential challenge and enhance health equity.
Wonderful. Next question here is, this is at the community level. How long do you know what's going on with every person in the community? I'm sorry, how do you know what's going on with every person in the community?
Oh, sure. Yeah, no, great question. I mean, it comes down to really where we started in this discussion, which is those thousands of discrete data points that we aggregate and process at a national level, and of course are refreshed as appropriate given the frequency of refresh for those data sources. That's that list of everything from Department of Agriculture to EPA to NPI, Housing Urban Development, all publicly available data. I will note, because that's a really thoughtful question, that if we, Lightbeam, are providing to one of our client partners the individual level health equity insights, where again, we need just the patient roster in order to process and then provide those insights at an individual level instead of a block group or community level. If we're providing those individual insights, then we go a step further, and we've contracted with different data providers to be able to pull in far more granular private data about everyone in order to generate those actionable opportunities at a much more specific person by person basis.
Great. Yeah, no, that's helpful. Next question here is, what data source is utilized?
Sure. Yeah. So the data source for Radian for the no-cost offering at a high level comes from these different areas, and then the data source for the more nuanced offering, I might even be able to pull up in real time here, includes third-party socioeconomic data and factors that are far more detailed. And you can see a list of some of these here. And this is how we take it to the next level. This is how we go down to a person by person basis and make predictions in what we call the JVON Health Equity Individual product.
Great. Yeah, very good. Next question here is it possible to add a 50-mile radius to the report? We are rural and have patients from 5+ surrounding counties, but 100 miles is a bit too far.
Good question. I tell you what, if you haven't already submitted a request, please make a note. Otherwise, when we connect, what I'd be glad to do is provide enough different 10-mile radius offerings that we can cover the appropriate population. Might be a little bit hard to code in a 50-mile radius, although again, not to turn it into a sales pitch. The very reasonably priced, even more detailed version of Radian, which is called the Javion Health Equity Community Offering, includes all levels of data across block groups. So you don't need to pick a radius. You can simply see those insights for whatever specific area you would like to.
Wonderful. Very good. And then the next question here is this available in Florida?
Yep, absolutely available in Florida.
And I guess the follow on to that is this available in all 50 states?
Yes, absolutely. Ready to go.
Okay, very good, very good. Well, oh, we did have a question that came in here. And this was asking about the slides and the recording. And yes, I will be sending this out to everyone right after the session today. So that is all the time we actually have for questions today. I wanted to thank our speakers, and you know, I think this was a great presentation. And as we close out here, I wanted to encourage everyone here to visit vbcexhibithall.com and go to the CareSignal exhibit booth. And there's going to be a link on the slides, actually, that'll take you right there. Or you can just go to VBC Exhibit Hall and you can find them there. And this is a great place where you can interact with their team, do a little bit deeper dive on what they're doing in the space. There's a lot of resources there and ways that you can, again, interact with the team and get in touch with them. And then finally, wanted to let you know that if you would like to reach out to any of our speakers, or to the CareSignal or Lightbeam team, feel free to do that. And Blake, if you could go to that last slide for me.
Absolutely.
Great. And so here's a couple emails here for you. The info@CareSignal Health. I think there's an H supposed to be on the end of that one. Or you can reach out to me directly, and I'm happy to put you in touch with them. And yeah, we'll get your questions answered. And if you want to submit an RFP or anything like that, then happy to help you to do that. So again, thank you all for coming, for attending today. We know you have a lot vying for your attention right now, and there's a lot of competition. So we appreciate you spending the afternoon with us. And we will see you on our next webinar. So thank you again to our speakers, and hope you all have a wonderful rest of your days. Bye-bye.
All right, Blake, it looks like we're the only ones left. Excellent job.
Thanks. I would love any feedback you have, especially while it's fresh, especially critical feedback. And thanks again for hopping on while you're on PTO, Charlie. I really appreciate you.
Of course, always ready to help. Talk to you later, Blake.